Future directions. So I'll just go back to the slide to point out the fact that even though we talked about this, the layers of these vessels that are sort of becoming hypertrophied or bigger than they should, you may also notice there's a large component here of inflammation, correct? So there's a lot of lymphocytic infiltrate here. And I think if you remember, our current therapies are targeting vasoconstriction and proliferation, but they're not really targeting the immune system itself. And we think that if maybe we can quiet this inflammation that's occurring in these lesions, then potentially we can prevent progression of disease. And so I'll just say that there's a large research cohort now that's looking at inflammatory agents or anti-inflammatory agents in trying to treat pulmonary hypertension. And this is an endorsement for our center at Stanford, but it was easy for me to think of at least 3 trials that are ongoing now with our doctors here. So Dr. Roham Zamanian, who's here, he's sort of the leader of our adult PH program. Dr. Mark Nichols is a very prominent researcher in the field, and he's also the chief of our division here at Stanford. Dr. Etta Spierker-Carter is a very successful basic scientist and pulmonologist here at Stanford, who they are all looking at various anti-inflammatory agents. So we have a multi-center trial that we're a part of that's targeting B cells with rituximab, anti-CD20, in the treatment of sclerosis-associated pulmonary hypertension. Dr. Nichols is actually looking at an LTB4 antagonist. So this is a leukotriene antagonist, which obviously is a part of the inflammatory pathway, where he's trying to use that in patients with pulmonary hypertension. And then Dr. Spierker-Carter brought this from sort of bench work to bedside. It's amazing the work that she's done. Tacrolimus, which is an anti-T cell agent, a calcineurin inhibitor in pulmonary arterial hypertension. She's just received funding to move forward with the first kind of clinical trial using this drug in our patients. Other future directions, I think we're talking about, you know, one of the problems with pulmonary hypertension is that there's just a delay to diagnosis. And we know that if we continue to have that delay in diagnosis, then no matter how aggressively patients are treated when we meet them, we'll never make up for that lost time. And we know that if we treat early, it actually changes the outcomes of our disease. So identifying patients early is very critical, or at least earlier than we're doing. Even to this day and age, the average time to diagnose these patients is about 2 years from the presentation of symptoms. Everybody says, oh, you just have asthma, or you just have a bronchitis, or you just have, you're anxious, and this has nothing to do with your lungs are fine, that type of thing. So I think if we can get better at diagnosing this earlier, we can impact outcomes. And so we're looking at how to do that, and potentially, even if they're not meeting criteria, for example, on a rest echo, we are trying to look into, can we identify things earlier by using exercise testing? We're also looking at being more aggressive in treating just upfront combination therapy with starting patients on 2 or 3 of those drugs at the same time rather than 1 at a time. Does that make an impact? We're looking a lot at what happens to the right ventricle in pulmonary hypertension, and are there agents that directly impact inotropy of the right ventricle that we can use? And then how do we even phenotype these patients in a more deep way using genetics, proteomics, metabolomics? So we're doing a lot of research in that realm to look at, you know, why do some patients respond to meds? Why do some not? Why do some patients have a 3-year outcome and some patients have been on these medications for 10 years, you know, and we're trying to determine even further response to therapy.